the intro
No,
slide?
ma'am. No, ma'am.
Okay.
After the just introduction. So, good evening, doctors and all the participants for today's session on cosmetic gynae disease series. And today is the episode 4. And the topic of the program is female sexual dysfunction. So, before starting the session, let me introduce our coordinator of the session, Dr. Poonam Misra, madam. Although we know very well Poonam, ma'am. Madam did her MBBS, DNB, FAM, FCG, and madam is the Director of Manas Hospital, Manas Gynae Cosmetology and Laser Center and Miracle Aesthetic Clinic, Lucknow. Madam is presently President of Indian School of Aesthetic Gynecology. She is the Chairperson of Cosmetic Gynecology, ISARM SIG, and members of Sexual Health Committees, FOXY, and many other societies as well. So now it's time to introduce our speaker, today's speaker, Dr. Shima Sharma, madam. Although all know very well, ma'am, but it's my formal responsibility again to introduce in brief. Madam did a DGMD, FICOG, FRCOG, and she is the senior consultant OBGN. And madam is presently the director of Srishti Femcare and Apollo Cradle, co-founder of NGA Pratisandhi Foundation, and a member of Sexual Health Committee, ASHA, FOXY, IS, VVD, and many more. And apart from that, in terms of academic activities, madam written many books, book chapters as well. So with this short introduction, now I would like to request Dr. Poonam ma'am to say a few words, and this session begins. Thank you very much, and over to you, Poonam ma'am.
Thank you so much, Mr. Suman. Thanks again, and thanks. I'm extending my actually heartiest thanks to the Shield Connect people, because you people are providing us the platform to get connected to everyone throughout India. And I think it is a global program. So we are actually connecting via this ISAG, Indian School of Aesthetic Gynecology. I am the president, and with us here, Dr. Prabhu Mishra is also there, who is the vice president of Indian School of Aesthetic Gynecology. And we are actually making our, the committee, and there Dr. Seema Sharma is also a very dear friend and a very renowned one. I told that she's our star speaker, and today's topic, a very special topic, female sexual dysfunction, is going to be taken by her only. And she is I have not taken her consent, so I'm not announcing the post here, but we will be discussing, and she very soon she's going to be there in the committee. So I am extending my warm welcome to everyone who have joined through this platform on behalf of this Indian School of Aesthetic Gynecology, that is ISAG. And this aesthetic gynecology group we have actually formed this has been dedicated for the public health and awareness. And it is also spreading awareness among doctors also, because many doctors are still not practicing the sexual health in their practices. They are doing their old practice with the obs and gynae and infertility, and they are encountering many patients with sexual problems, because this is something very important for their infertility part. But yet they are not opening up, and they are not letting their patients also to open up in their OPD, because of maybe that is because of their busy schedule or something like we have never thought of this, that we should discuss one-to-one to the patient and to her husband also for their sexual problems. But yet this is our actually this, you can say that we are trying to do something in this regard also, as we being cosmetic gynecologists. This is a new branch and everybody is taking interest in this. Every cosmetic gynecologist is a dedicated person for sexual health also, because I have always been saying, this is my pet sentence, I like this, that this cosmetic gynecology is intricately woven with sexual wellness of a patient or sexual health of a patient. So we are working on both of these things, because we are dealing with the body and the genital parts, and we are making them healthier. And this is not only related to the beauty or looks of a patient, genital parts and the body of that patient, but this is also working with the functions, the functional problems related, like the vaginal hyperlaxity syndromes, the prolapse, and the incontinence part, that is also being taken care of. And that is why we are trying to, you can say that it is a simple effort, it is a primary effort of ours to go for this through Indian School of Aesthetic Gynecology. With us here, Dr. Prabhu Mishra is also there. He's the vice president, and he's the president of International Association of Regenerative and Stem Cell. This is something, a huge platform, and I'm very happy me, Dr. Seema, and all are associated with him in that platform also. So I'm inviting him to say a few words for today's topic. Dr. Prabhu.
Thank you. Thank you so much, Dr. Poonam. Everything already you have explained, and it's my honor and pleasure to have you both here. Because, you know, like we were discussing around when we have created this Indian School of Aesthetic Gynecology. Idea behind that, like we were already having this ISRM for last 10 years. We are doing many academic activities in regenerative medicine. But when we are discussing about this prevailing problem like a female sexual dysfunction, categorized into 3 segments: regenerative, aesthetics, and cosmetics, and the functional aspects. So we thought, like, let's do, because it's a prevailing problem. If we'll talk about the only today's topic, the FSDs, somewhere around 40 to 50% women suffering and have suffered at certain stage of their life this kind of issues. Like no doubt, sometimes we call it like it's a pills to cells, from the estrogen therapy to nowadays like energy-based devices, PRP, fat grafting, stem cells. So this kind of advances, and today Dr. Seema is going to talk about that. The idea behind to bring this association on 3 scales, like to bring the awareness to the society, to the community, because still a sexual, because many organizations like Foxy and many others, and the individual scale, some doctors and some associations or NGOs, even Dr. Seema, amazing work through their Pratisandhi NGO at individual scale. It's amazing work and globally recognized and known to of. So this kind of world leaders, those who are promoting and creating the educational platform and not educational platform to solving that challenges as on individual scale. So we thought, let's make this association, bring this association, create the awareness among society, community, and medical fraternity, and through the educations and awareness. So this is the basic objective behind that, taking not much time. Now, thank you very much, everyone, all delegates, those who are joining, and this expert lecture series will be continued as much we can give. Again, on 21st, we are having amazing topics on the sexual medicine and the cosmetic urogynecology and andrology. Must join on the 21st, 4 p.m. I'll share the link into the ISA group, so you can get the joining link there. And welcoming you, Dr. Seema, to have your wonderful experience on this journey of this. Thank you very much.
Thank you so much, Dr. Poonam and Dr. Prabhu Mishra. You guys speak so flawlessly, and you know, I sometimes get goosebumps. So, do I have your permission to start?
Yeah, oh, of course. It's already you are. We need the permission to stop.
No.
Actually, we are interfering now. It is the dais is yours, the whole the webinar is yours. So yes, we are now going into the vanishing mode, and you are here all over.
All right. So thank you once again, Dr. Poonam, for making me part of today's series. I want to talk very basic stuff that most of the gynecologists would want to hear. So this female sexual dysfunction, we're going to be talking about what exactly is normal sexuality and how do we distinguish a normal sex issue from a dysfunction, along with certain current clinical considerations and recommendations, and we would wind up with a summary. So before we go on to the dysfunction, we understand as a doctor that, every person is different. A woman is different from a man. Every woman is different. So every woman has a different sexual response depending on her physical attributes, how she's been brought up, what her psychology is, what is her social and cultural issue. For example, if a woman is in US or in India, Indian women would see things like masturbation, like oral sex, like infidelity, or sex before marriage with a different person. Everything is being viewed at a different level in a different context by somebody who's been brought up in India and versus somebody who's been brought up in US. So when we see a patient, we need to see the person in totality and have a holistic outlook about the person. Now, I think there is some problem with my, okay, hang on. I think the formatting went wrong. Okay, so when a woman comes to us with sexual dysfunction, she complains that there is a problem. How do we understand what is the criteria that makes us understand there is a dysfunction versus a transient problem? So when a couple comes to you and tells you, well, they've been having this recurrent issue over the last 6 months, and the issue can be she has no desire, she has pain, she has difficulty achieving orgasm. It could be in any of the baskets. But there is a sexual problem which is persisting for at least 6 months. So we need to take a good history taking that exactly when did the problem start? Has it been present from before, from forever, ever, that the woman can remember? Or it has just started and it has been persistent for the last 6 months and more. And the problem should be there for more than 75% encounters, like 3 out of 4 encounters, the woman should have a problem, and we will just be coming to the problems that she will have. And the issue should be such that it causes marked personal distress or interpersonal difficulty between the man and the woman. And this problem is not accounted for by a medical or a psychiatric condition like depression, and she should not be on antidepressants, which are directly responsible for her low libido, or she should not be under the effect of a substance abuse or a drug, which is known to cause sexual issues.
Sorry for interruption, ma'am. Slide is not showing you.
Sorry?
Slide.
Slide is not. What is the problem?
Slide is not showing. So you are not sharing this slide?
I am sharing. Really? Hang on.
Ma'am.
I'll share again.
Yeah, sure.
I thought I did. It's showing on my screen. Let me close it. And I'm sharing screen again. Can you see?
Yes, ma'am. Now you can open your slide.
No, hang on. I'm not seeing my screen now. Is there a problem?
No problem, ma'am. Please open this your PowerPoint.
No, but I can't see my PowerPoint.
Yeah, this one, maybe.
Why am I not seeing my own thing?
Ma'am, you have saved there, so yeah, we can see your screen.
You can see my.
Yes, madam.
Okay.
But PowerPoint is not open.
Okay. Sorry, can you see my PowerPoint?
No, ma'am, it's not opened here. Yeah, now we can see. Now we can see, ma'am. Yes. Ma'am, can you please full screen? Just this slideshow. Yeah. Play from current slide. It's okay.
Okay.
Yeah, fine. Thank you.
Okay. Okay. Now, when we talk about sexual dysfunction, a patient can come to us, and I dread such patients sometimes. At the end of the OPD, patient will come, Doctor Saab, mera dil nahi karta hai sex karne ka. She can complain of lack of sexual desire. She could have that I don't feel aroused, or I don't. People will ask you, what do orgasms feel like? I have never climaxed. If you ask direct questioning, they have never ever had the feeling of a sexual high. Or they can complain, which is a common complaint again, that they have pain during sex, or she could have a combination of all these. Now, we need to first understand what is troubling the woman. So there was an earlier classification which we used to call as the DSM-4 classification, which I'm not get into because now this is obsolete. And for the last 10 years, we have the newer classification, that is the DSM-5. DSM-5, if you go back to your MBBS days, was Diagnostic and Statistical Manual of Psychiatrists. It is the 5th edition, and this is in USA, and it is responsible for giving all classifications of all diseases. So for the newer classification of female sexual dysfunction, we have 3 main categories. One, either the woman doesn't have a good arousal, or she is lacking arousal, or she has pain or pelvic pain, penetration pain or pelvic pain during sex, or she has an orgasmic disorder. So these are the 3 main categories we need to classify, and it is fairly easy. Life is simple. A lot of times, we say, patients come to us that they have not consummated their marriage because they've had pain or they are fearful. That is one criteria. There is another criteria when she says, when I don't feel like having sex, and it's causing a discord between and my husband, or complain, doctor, I've never ever felt pleasure while having sex. What can I do? Only talk about holistic function, because as such it's every single. So how do we diagnose a female sexual dysfunction? Of course, like as gynecologists, our antennas are always up for any problem that patient has. Patient with infertility comes to us, we automatically think, have they ever consummated their marriage? You suspect that there is something wrong. Or the patient will directly tell you, well, they have consummated, they've never had a vaginal sex, or doing it wrongly, or they are having pain, or XYZ, whatever history. And then we examine and then move on. So how do we screen for a female sexual? We need to ask questions. We are very busy people as gynecologists, and we need to ask questions in a manner that if she understands English, talk in English, understands Hindi, we cannot keep yapping in English because she will not understand anything. We can make our own small questionnaire, simple thing that is there are simple questions. You can actually modify the language according to the kind of clientele. That simple things like, how long you, and do you want to talk about it? These kind of questions, even your nurse or your receptionist, you can have a sample questionnaire, and the the nurse can it has been that
Poonam madam, some problem is there. Madam left suddenly.
Yeah, everyone. Yeah, seems like Dr. Seema is having some power cut maybe there, because sudden disappearance actually reveals that yeah, she's back. Hi, Dr. Seema. Actually, you disappeared suddenly, and we were actually thinking that some power cut was there. Is this?
I think sorry about that.
No problem. Yeah.
Okay, can I carry on? So
Yeah,
I was talking about this questionnaire that we should all have. wherein we can talk to the patient in her language and ask eventually what seems to be the problem, because women are not simple creatures. Like, unlike men, who are very clear that they want to have more sex, and it's more like a physical thing with them, and they want to have good erections. Women take hours to open up if they don't get the right environment. So we need to be little sensitized to the patient, her environment, her cultural background, and her needs. There is
your slide. Yes, you have to share your slide again.
God.
No problem. Just go for
why I don't know why this is happening, because I thought I can see my slides.
Just go for the share screen again. Go on the Zoom page.
Madam, the same way. Just share screen and then screen button. That's it.
Yeah. You got? No. ESC button. Go for exit from the.
I think I should have sent you the slides.
No problem. It's very easy. Yes, it's there.
Can we see now?
It's there. Yes.
I'm so sorry for the whole thing. Okay, can we see now?
Yes.
Sorry. All right. So there was this survey which said that almost 50% women after delivery and almost 80% postmenopausal women want to talk about their problems pertaining to sex, but gynecologists don't have time. They don't want to talk about it. And if the couple starts or initiates, they are met with very stern looks or stern eyes, and nobody wants to talk about it. So while taking the history, also we need to keep in mind that there are certain medications like antidepressants, mood stabilizers, among them the weight loss medications and anti-allergy medication, antihistamines, could be the ones which are affecting a female's sexual drive. Things like birth control pills may make them more free, but it reduces desire, it reduces libido, and also pregnancy and delivery related female sexual disorders caused by trauma, tears, breastfeeding, all of them can cause decrease in the libido. I'm hurrying up because most of these are actually, the causes may be known to the gynecologist. What mostly gynecologists want to know is how do we treat them? So I will quickly come to the treatment part. One important thing is that endocrine disorders can also lead to female sexual dysfunction. So if you see a couple, or a man or a woman, either, if there is no diabetes in a person, so the number one cause of sexual dysfunction is diabetes. And if the person is euthyroid and non-diabetic, prolactin could be the dangerous thing here, which increases in the postpartum period, causing vaginal dryness and all sort of on insertion. And if it is a man, then estrogen and testosterone are two things that you need to do. You need not do the whole paraphernalia if the person is non-diabetic and euthyroid. So this was about history taking. And coming to the physical examination, we must examine a woman with who's complaining of female sexual dysfunction, and always try and use a mirror to show where you're touching. Be sensitive, look carefully in bright light, look for endometriosis, look for blue spots, look for fibrotic issues in the vagina. So many times women are complaining of pain. You put in a finger, they will tell you exactly where they are feeling the pain. So the diagnosis of vulvodynia, vestibulodynia, or a fibrotic inlet, or a badly stitched episiotomy, or if there is any infection, is there any condyloma, all these can be seen. And also please take a picture when you are seeing, so that even if you don't have a mirror, though women love to see themselves in the mirror, but then if you don't have a mirror, of course, you can click a picture on the mobile and show them, so that when the treatment happens, they can also compare the before and after, and also they can understand where the problem is. So the current concepts in the treatment of female sexual. So far we have talked about that there are three main categories that you can put there. These are the three main baskets that the female sexual dysfunction comes under. Either there is a low libido and low arousal, B, there is a problem of pain during penetration and pelvic pain on sex. 3, there is an orgasmic disorder. So though of course there are 3 clear-cut baskets according to DSM-5, there can be a good amount of overlap between all the 3 categories. Like for example, if we have a postmenopausal patient or a perimenopausal patient and she says, well, I am having dryness. So okay, she has a GSM. So if she has dryness, obviously the sex, the to and fro movement of the penis is making her having pain. Now her mind switches off because sex is no longer a pleasurable activity. So then she reports not only pain, but she says, I don't have, my libido is going down and I have no arousal. I don't get orgasms because, so you need to go back and first treat her GSM, treat her dryness, and then gradually the pain part will become better. So then, it will help to break the cycle of pain and then decrease desire and so on and so forth. So current concepts are, whenever you have women saying anything issue, any pain or decreased desire or no orgasm, start with non-medicines, no medicines. First thing, talk to her. Try and identify the reason behind her problem. And always low-risk interventions should be adopted clearly. There are few interventions which have been globally accepted that these should be adopted early on in the treatment. Make sure that before you have started medicines given medicines to a person, she should have at least one counseling session with the relevant person. Now, if you feel couples have a problem, they can't talk to each other, the marriage is breaking, so they would go for a couples therapy. Or while talking to the couple, if you feel they don't understand the sex part of it, like how to proceed, they are not aware about their sensory zones, then you need to say go for targeted masturbation. You need to teach them sensate focus and you don't have time, then you can ask for a sex therapist. So there is a difference between what therapy to adopt. It is not just any counseling. You need to send the person for the right counseling. If you want to go in for sex therapy, then it is better that individual person goes rather than the couple. And the individual person learns and then you can involve the couple. Psychotherapy, essentially again, we as doctors are not very learned on these things. So you need to have the right person in your clinic or you need to have the right referral system. Lifestyle change, of course, weight reduction, exercise, eating better, improvement of body image, all these are things that again require a lot of time in your clinic. And, but we must insist that they need to control their diabetes and they need to have the right body weight and exercise, because by themselves, endorphins that are released during exercise will go a long way in improving her body image as well. Pelvic floor dysfunction and treatment of early incontinence and prolapses, needless to say, is a huge thing. You need to treat pelvic floor dysfunction as a gynecologist. मतलब ये धर्म है हमारा, क्योंकि lot of women cannot enjoy sex for the fear that they are incontinent. While they climax, they leak a little bit of urine and they feel very embarrassed about this fact. And unless people ask about it, they will not tell you. So you need to be aware about these things to ask that what exactly is the problem. And if you feel that she's had a normal delivery, her cervix is last, and there is a cystocele, there is a rectocele, and she is incontinent, the stress incontinence is there, treating pelvic floor will definitely go a long way. So these are a few things which apply to all categories of female sexual dysfunction. Now, coming specifically to the number 1 disorder, that is your lack of desire and arousal. Now, when a lot of times women will innocuously come, "Doctor, mera man nahi karta, kya kare?" Really, it's a simple question, but you need to ask a good amount of history. There are specific questionnaires available for sexual interest disorders, but mostly interest disorders need to be treated with hormones, provided you have taken care of the rest of the counseling at least once and you've ruled out everything else. Now, what do we give? Androgens are the first line therapy. Mostly interest disorders are in perimenopausal and menopausal women, because in a younger women, usually interest is there. Mostly younger patients would usually come to you with pain. So testosterone is something which has been quite at the center of all researches these days. Abroad, it is available as a patch. In India, it is not available as a patch. We have a transcutaneous gel. Now, the problem with testosterone is we don't really have values for women. Unlike men, where the andrological society or urological societies will say, okay, 300 is what it is. Beyond less than that, you need to supplement testosterone. More than that, you're fine. For women, we don't have a specific value. We generally assume in a perimenopausal women, testosterone values are 10% of that of a man equivalent age. But we still don't know how to get testosterone because it is not really FDA approved. We have been giving gels, transcutaneous gels for the treatment of low libido in a perimenopausal and a postmenopausal women. Now, DHEA as a 1% vaginal insert is also available, but don't give. A lot of people have been giving, okay, DHEA is orally available. We've been giving it to improve the ovarian reserve in infertility patient. No, systemic DHEA is of no use. Estrogens, we've all been giving for disturbing vasomotor symptoms when patient has hot flashes, patient has vaginal atrophy. Tibolon is not available at the moment in India because it was not used. So I think the company has stopped now the manufacture, though that was a good drug earlier. And now the newer drugs are flibanserin and bupropion. Along with that, certain other drugs like bremelanotide and sildenafil, which is used for male infertility, are also being part of some trials. And a lot of gynecologists are loosely giving sildenafil, Viagra to even, we've been giving it to improve the endometrial receptivity. But even to improve the sexual interest, people have been using it. But FDA doesn't approve it for this purpose. So coming to, I will just say a few words about flibanserin. Pink pill, lot in vogue. Lot of feminine articles on female answer to Viagra. Not really freely available in the Indian market, but online it is available. People have used it. It is a prescription drug. FDA approved it in 2015 to use it in women with low sexual desire, and people should not be on antidepressants. Men cannot take it. It is only for use in premenopausal women, and it has to be taken once at night, every night. And, it does seem to improve the sexually satisfying episodes that the woman has. But you need to continue it for 6 weeks. And if you don't see any improvement, you need to stop. There are a lot of side effects. Important thing is you have to tell her that she should not be taking it with alcohol. So ADI is a common drug, which is a lot of sexologists are also using for improvement of female sexual arousal. Other drugs which are there, I said 1% DHEA preparation. Also, it helps in GSM. Estrogen creams we have been using forever. Evolon and Premarin creams, they are available. Bremelanotide is a newer drug which is now FDA approved since 2019. It is an injection that the woman has to take. It is something like an insulin injection taken 45 minutes prior to sexual activity. One injection she needs to take in 24 hours. Again, it causes a lot of headache and flushing and nausea. She can try and see, but she should not take more than 8 injections per month. So the first line advice, of course, I was just talking about the medicines that you have a basket on, like the testosterone, androgens, estrogens, DHEA, flibanserin, bremelanotide. All these are drugs available in your basket. But first line advice for low desire in a woman is let them speak to a sex therapist or a marriage counselor. Let them talk about their sexual fantasies with the counselor. Have a sense of connection, and they can plan romantic dates, change their antipsychotic medication, antidepressant medication if they are on any, talk openly about sex. And if they show more affection, it has been shown to improve desire in a woman, because essentially a very emotional creature. If there is the man is there who she can rely on, who has responsibility and shows more affection towards her, it has been seen to improve desire in a woman. Coming to the next one, the orgasmic disorder. So traditionally, it is very hard for gynecologists to ask and talk about orgasms. So it is easy to just talk in simple language that do you feel happy after sex, instead of using the word orgasm, because even your patients may not really understand orgasm if they haven't really experienced it. So the sexual high or the relief that they get after sex. So do you climax? All those are simpler things. And traditionally, we have been giving lubricants and moisturizers, and these have been increasing the lubrication and making friction less while sex. And once the pain is relieved, orgasm can be achieved better. Sensate focus exercises are very, very useful, wherein essentially we ask the couple to find out more erogenous zones rather than the genitalia, and also increase, the pleasure in a woman. And of course, sex education and directed masturbation. Really, I am rushing through them. Each sentence can be talked about for an hour, but essentially this is not really a gynecologist's domain. So at the moment, I'm just skipping it. Vaginal lubricants and moisturizers are something that we've been commonly using. Thing to understand, do not give LOX ointments. A lot of people give xylocaine jellies, which will actually reduce the sensitivity and it will not enhance the pleasure. So there's a difference between LOX ointment and lubricating jelly and moisture. So pelvic moisturizers have to be used independent of sexual activity. She needs to insert the vaginal moisturizer. For example, is coming to my mind of pelvic gel. It can be any company. So you need to insert it every day. 7 days it increases, gains moisture, and improves the lubrication of vagina. And also the lubricants are there which can be used on the penis, on the outside of the vagina at the time of sex. So these are the two things which have been traditionally used. And now we have a clitoral vacuum device. We have cosmetic procedures, like we can enhance the erogenous zones. PRPs are there, collagen injections are there. We have fillers, we have nanofat, clitoral, all these cosmetic vulvovaginal procedures are aimed to improve the orgasmic, the pleasure associated with orgasm, especially when the woman is aging. The sensitivity reduces, and all these things can improve the orgasm, and she can enjoy her sex for a longer time. Drugs like sildenafil have also been shown to improve the orgasmic activity. And pelvic floor exercises, of course, have always been there. We've been telling patients Kegels exercises. It improves the blood supply to the area. Anything you exercise, there is more angiogenesis in that area. The muscle quality improves, and the orgasm quality also improves. So this is what we've been using in my clinic for the last 5 years. Patient needs to sit on the chair. You must have heard it in other lectures also. This is to improve this is a functional magnetic stimulation. It is used to improve the pelvic floor tone, and also for many other functions. Patient needs to sit on the chair for 30 minutes, and a 30-minute session gives equivalent to 10,000 Kegels exercises. Coming quickly to the last criteria, that is if the woman has pain during sex, how do we treat? We need to, again, treatment is to be based on the etiology. Is she a young person? Is she a menopausal patient? What is happening? While examining, you might see an endometriosis, you might see a septum, you might see that the introitus is very narrow, needs to be opened up. She needs to use dilators. Or if she's in the postmenopausal or the perimenopausal age, there could be the genitourinary syndrome of menopause. So etiology, we need to find out what is causing the pain. We look at the patient, we examine, we take what's causing her pain. So treatment, if she has GSM, which is pain, we need to give her lubricants, moisturizers, low-dose vaginal estrogens, and low-dose estrogen. Don't be afraid. A lot of people feel, no, just give for 1 month, 2 months. So you can go on now, at least for 10 years, you can easily go on to low-dose vaginal estrogens without any problem. Then vaginal DHEA, oral ospemifene, and energy-based devices, and RF, of course, can are the new things in our armamentarium. Another reason for pain, vaginismus. Again, we can have a huge lecture on vaginismus, whether it is primary, secondary, or situational. And of course, we need to treat vaginismus depending on what is causing the vaginismus and what is the etiology behind it. If there is infection, we need to treat the infection. If there is a pelvic floor hypertonicity, we need to give a functional magnetic stimulation. Now, the newer add-ons are botulinum toxin, and again, the electromagnetic stimulation through that chair that I just showed you. So this was in all overview. The next two slides are essentially for the physicians I just picked it up online. This just summarizes as to what we need to do. You take history of presenting, history, examination, investigation is what is mentioned here. We've essentially done, so I'm not going to come back to it. History is very important. So if you feel you don't have time, just let your front desk person or your nurse or your junior doctor fill in a performa, talk to them, because they will take time to give you the reason. They need to think about it, and you will not have that much time and you will get irritated. And do examine all of them. A lot of times we feel, well, there is a vaginismus, but actually we've been rushing the patient. The patient is not comfortable to open up. There is no problem as such. So we need to be gentle. We need to give them time, which is difficult for us because we also have so many antenatal patients waiting. And then, these patients seem very simple to please. Antenatal patients will just come and go in a minute, and versus the sexual issue patients, who will take age to get up, and they pay the same amount of money. So, when she has, if she has pain, local hormone therapy, counseling, pelvic physiotherapy, suppository, rest of the things are not, the first couple of things are what are important. If she has low desire, again, I said desire is corrected by hormones. Counseling, of course, ribancirine, and low arousal, they are essentially the same. So we don't have to go on. This was a slightly older slide. And if she has orgasmic dysfunction, then mindfulness, sex therapy, and sildenafil is what is effective. So what does the American College say? Of all these things that we have talked about, FDA says just give low-dose vaginal estrogen therapy for the treatment of FSD for menopausal patients. Or you can give low-dose systemic hormonal therapy. Hormone replacement is what we call it. Ospemifene is also very good as an alternative if the patient has dyspareunia associated by GSM. As I said earlier, DHEA orally is not effective. We need to have DHEA vaginal creams for the treatment of vaginal dryness. The next level of interventions, psychological interventions and transdermal testosterone. Sildenafil should not be used except outside clinical trials. Intravaginal prastrone, which is DHEA, and low-dose estrogen and ospemifene can be used in GSM. And SERM therapy is not recommended when it is not due to hypoestrogenic states. Lasers, again, FDA, at the moment, the position statement is you don't use it unless this is part of some kind of research. Flibanserine, they are approving for the treatment of desire disorders in premenopausal women, but it has its own share of side effects. Level C recommendation, caregivers should initiate a clinical discussion about sexual function always. And evaluation should always include a comprehensive history taking and physical examination. Lab testing usually is not necessary, but prolactin, I feel, thyroid, prolactin in women, sugar levels, HbA1c, testosterone and estrogen levels in a male should always be done when there is a problem in the couple. Level C, again, they are talking about transdermal testosterone. That is a level C intervention. A lot of gynecologists in India are using testosterone freely, but please just don't use incessant hormones unless you are following up and you're doing a follow-up with the patient every 3 months. And make sure that in 4 weeks, if the patient is not showing any improvement, you must stop the hormones. Pelvic floor therapy is useful for all sorts of female sexual dysfunction. Lubricants, tropical anesthesia, vibrators, and moisturizers may help to reduce dyspareunia. I will end by saying that no newer modality can replace a traditional good history taking and giving the couple a chance to speak. So please be patient with such couples and try and make a diagnosis first and then try and address her concerns specifically. Thank you so much. So over to Dr. Poonam.
Thank you, Dr. Seema. It was actually a wonderful lecture. The topic is least talked about and something so important, because history taking and the most important part is history taking. Yes, and once you just screen out, once you just get to know that the patient is to be referred to someone or is going to be treated by yourself, like you did a wonderful job. Actually, you just explained each and
Actually,
every.
the topic is so big that on everything we can go on and on, but I just thought I will give an overview first.
Yeah.
And then subsequently, we can talk on each topic separately, because desire disorder, pharmacotherapy,
Exactly. Yes.
everything. You've been taking lectures on vaginismus and botulinum toxin separately. It's really a huge thing.
Exactly. Yes. And I think each and every slide needs complete elaboration, and in itself, it's a huge topic, and each and like all those arousal disorder, orgasmic dysfunction, and penetrative disorders, and everything, the newer classification, each and everything is to be elaborated in our further sessions, I think, and we would be doing that. Are there any questions, Mr. Suman?
Yes, ma'am. Let me check, ma'am.
Yeah. So
Meanwhile, many doctors joined here also. So if any questions, they can.
come.
Madam, one question that what kind of antipsychotics need to be provided in case of a patient is suffering from this kind of problem?
We can't provide antipsychotics ourselves. We need to send the patient to a counselor or a psychiatrist who, if you feel that the patient has a depression or or a psychosis or something, we can't be providing antipsychotics just like that without taking adequate treatment and without psychiatrist help.
Thank you very much.
Yeah, actually, according to us, we all gynecologists, cosmetic gynecologists, it's a team effort. And your history taking actually segregates all those patients, like in which streamline we have to send those patients. Like if the patient is having, you feel that she is having some sort of psychological issues, you have to refer to your psychiatry, the psychiatrist friend. So we have to make a team, as the cosmetic gynecology itself is a team effort. We need a dermatologist, we need a psychologist, a psychiatrist, a plastic surgeon, a urogynecologist, everything. Like, and if you have got some sort of training, or if you feel that you can do justice to your patient, then go ahead and treat the patient. What is your opinion, Dr. Seema?
Absolutely.
Yeah. Exactly.
No, actually, we need to be safe doctors ourselves as well. And I think we need to take the help of different people, and we have a multidisciplinary team effort for everything. As gynecologists, we don't have time in the OPDs, to spend for an individual patient, take detailed history assessment, because there are various psychiatrist tools available now wherein you will kind of label a patient into a specific criteria. So I don't think there is any need to jump into their domain. SSRIs commonly can cause reduced libido, and if the patient is on that, we need to probably replace that or reduce the dose. And they can also, in a man, cause erectile dysfunction. So if a woman says my husband has a problem because of which I don't enjoy sex, then you need to basically do a history taking from the man as well, and then move on from there. And maybe refer the patient to a urologist or somebody who can look at the patient. So the whole point of today's talk was that we need to understand what is female sexual dysfunction. Just a lot of times women feel, oh, I don't have the desire. So if you ask in detail, what do you mean by that? They would say, well, my husband wants sex every day, but I want to have it like once a week. So I think that is not a dysfunction, because that is just a desire discrepancy, that, a man wants it more often and a woman doesn't want it. So nobody knows who's right. Is the man asking for more or the woman asking, having less? So, in that situation, a couple therapy would help, in the sense they need to find a middle ground that, this is what it is going to be. And then, we need to understand where medicines are needed. Just blindly giving them testosterone or androgens and all are not going to be sufficient. So we identify the dysfunction, B, categorize into which basket we want to put the dysfunction into. Desire disorders, or desire and arousal disorders, or orgasmic disorders, or pain. So clearly we have 3 different baskets. We can move on from there, because then we understand what is the way forward, and then treat the patient's concern first, and understand that, patient can have concerns in all 3 baskets. But a good history taking, have a pre-printed formats in the local language and ask the patient to fill in. That will save your time, and then identify the problem and then move on to give the treatment. So
Absolutely.
I will talk about more and more in the coming sessions.
Definitely, yeah, this topic is something very important, and yes, and we have to incorporate such practices in our day-to-day practice, that we have to go in detail, because many times we just get to know that the problem is absolutely sexual. The patient has come for the infertility treatment. The in-laws have brought them to get some treatment, so that the issue is not there in their family and some problem is there. They are coming for IVF and other things. And there you come to know that the problem is there only. There's some counseling or some sessions with your psychologist friend or psychiatrist is going to treat everything. So, Mr. Suman, I think
Yes.
No more questions are there, and few
Yes, ma'am. Yes, ma'am.
very dear seniors and friends are there through the speakers link, because many were not able to join through the delegates link. So I just shared that speakers link to them, and I'm so happy because few have joined through this link also. So I am just extending my gratitude to all. And friends, because of you all, we are here and we are trying to do something for this subject, and like your support is always needed. You are there to encourage us, and your like suggestions are also needed in our ISAG WhatsApp group. If you think that like some suggestions are there with you all, your topics, you can suggest your topics, you can ask for anything. Like we are planning for some trainings also, some small trainings, something related to aesthetic medicine, something related to cosmetic gynecology, so that we can combine both of these fraternities, so that a person can do justice with the her cosmetic gynae practice, her or his cosmetic gynae practice. So I'm welcoming you all for your suggestions and for your queries in our WhatsApp group. And we are going to just end this session. Goodbye.
Thank you so much,
Thank you.
Dr. Poonam, for
Thank you,
Thank you
Dr.
very much,
Seema.
ma'am.
Thanks a lot
Thank
to
you.
you
Thank you
because,
very much, ma'am.
because
Thank-
I know you were so busy and you gave this time and just you spared this time. You were so busy today also. It was very difficult for her to take this
I'm
1
so
hour.
sorry for the trouble that we had in between.
No,
Be more careful.
this happens, and everybody knows like this. This is the
Thank
era
you.
of webinar, and everybody is well versed with all those glitches and everything. See you all. Bye bye. We will be
Thank
coming
you.
up with our next session the next month.
Yeah.
Thank you very much.
Thank you. Bye bye.